Okay, we can start. Okay.
Okay.
Okay, just a small introduction of the project that are funding these activities. I'm Valerio Di Tommaso, president of ECOS, and the project is the European Alliance for Sport and Mental Health. The project is funded by Erasmus Plus program, and now today we start with this experimental training that the teacher is Professor Gaia Sampogna from University of Vanvitelli from Italy. And I would just a small introduction on the project, because EASM project is a very important project for us, because we are trying with this project to create a favorable environment for a confrontation between sport technician and mental health operators, because we really believe that the coaches, can be of great help to psychiatric rehabilitation equips. Our real goal is that the presence of sport technician in psychiatric rehabilitation place could be mandatory, because in our opinion, sport is very important for the guys that has a problem of mental health. So, but now I stop my introduction, and I leave the floor to Gaia Sampogna, that will manage the overall lesson of this training course.
So thank you very much, Valerio. I am really happy to be here today. I really hope that you will join, you will be happy in participating in these lessons. And as you already know, we will have in total 6 lessons. And as you have had the opportunity to read in the summary, we expect to have a very interactive session. And now I will start to share my screen and show you some slides. And one moment. Okay, so this is, can you see the slide? Yes. Yeah, this is the program for today, and as you can see, it is a very really dense program, I would say. But first of all, I have reported here some technical details, because of course I really would like to hear from you about your opinions, your ideas, and also what you already know about mental health. Because as Valerio told, I am a psychiatrist, I am a medical doctor, and I work in Italy at the University of Campania Luigi Vanvitelli, and I will try to share with you some information regarding mental health and severe mental disorders. But of course, I would need your help to make these sessions very interactive, because of course, this is just a sort of theoretical background that we will discuss in these afternoons. But at the end, you will be the person that will be really in contact with patients and are requested to perform the sport activities. So this is the reason why we asked you to have your microphone and your camera on, just for recreate a sort of in-person meeting, although we are located in different regions in Europe. And I guess that you already filled in the module that Stefano sent you by email yesterday evening, but you can find it at this link, and if you wish, I can send it again in the chat of the Zoom meeting. And so now Valerio has already provided us with a very general global overview of the EASM project, and as Valerio told us, this project has been funded by the European Commission, and so we are very proud to be part of this project. And I personally think that it is very important to promote these kind of activities with our patients in order to improve their quality of life and their possibility to recover from mental disorder. And today here there is also Stefano Moliterni from ECOS, and Valerio, that is the president of ECOS, and myself, and also we have also Samsa from Finland, that is another partner of our consortium in the research project. But I guess that I have already say a lot of things, so I would like to invite you cordially to introduce yourself and just to explain us who you are, what you do, and also why you decided to take part to this training course, because you know it is not so, I would say, easy or straightforward to understand the reason why people that are mainly involved in sport activities decide to take part to this kind of a kind of different activity. But I would also give the floor to Stefano just to say hello to everybody, and also to Samsa, and then to the other participants to this first lesson today. So please, Stefano, go ahead.
Hi, everybody. I'm Stefano Moliterni, and I'm a project manager of ECOS. And together with Valerio and the World Consortium, including Gaia, Samsa, Jonathan from Everton in the Community, the University of Costanza, we developed the EASMH project that then was approved and funded by the European Union. And we are together here to undertake this training session that then will have a practical training during the next month till the end of this year. So after these online sessions, as you read in the in the summary we sent, after these online sessions, which will end in May, at the end of April, May, hopefully. Then you'll be involved in a practical training in your communities with psychiatric patients from mental health services in each country here present today, and you'll have a time of around 6 months to undertake this practical training. And of course, if you have needs, requests for everything, you can write an email to us or call us, and we'll answer to all your doubts and questions.
Just one more things before then I need to leave. I will listen the recorded lesson. I put in the chart the website of the project just to understand the total environment of this project, because you are now representing 4 partners of the consortium of the project. No, we are 2 from University of Costanza, 2 from Finland Federation of Sport, 2 from Italy, from ECOS and Italian Rugby Federation, and 2 from Everton in the Community. So you are representing the partner that selected you. I put in the chat the website of the project. I don't know, maybe Gaia has already provided in the slide, maybe, I don't know, but I put in the chat because it's very important also that you understand which is the situation, where the general situation where we are. Okay, thank you.
Thank you, Valerio. Then Samsa, please introduce yourself.
Okay, so hello everybody. My name is Sampsa Kivistö and I'm working for the Finnish Regional Sport Federation. We have 15 regional sport federations in Finland and we are the second biggest. And my responsibility in our organization is physical activity and adult sports. So these projects fit quite well to what we do. And we have two coaches here. I think Sami, the other coach, I don't know, because I cannot see who is attended, but he will anyway attend also later. So we have two coaches here and I'm like listening for a while and then I also have to leave. But hello for everybody.
Thank you. So also I have seen that Johnny Garside has joined us. And Johnny, can you hear me? Ah, okay, now I can also see you. You are
Yeah, I can hear you. Can you hear me?
Yes.
Okay, afternoon everybody, lovely to see you all. For those that don't know me, my name is Johnny Garside and I'm the Health and Wellbeing Manager of Everton in the Community, which is the official charity of Everton Football Club in the UK, based in the city of Liverpool. We've been involved with the EASMH project from the start, and previous to that, we're also involved in the Sphere project. So we have two of our coaches who have been put forward for this fantastic training. I'm joined by my colleague Lewis, who's on the call, and also Lucy, who unfortunately can't make it. She might be able to join a little bit later, but my colleague Lucy McLean as well.
So thank you very much for joining us today, and we look forward also to hearing from the two coaches from the UK, and also they will be asked to introduce themselves. So now I don't know. I would like to go through each of us. So the next person that I see on my screen is Alex Oltean. I don't know if I have pronounced your name correctly. So please, Alex, introduce yourself and say something about you to us.
Hello, yeah, you pronounce it right. It's Alex Oltean.
Okay.
I'm a physiotherapist to the Constanța basketball team.
Mm-hmm.
And I'm also a volunteer coach for the Special Olympics here in Romania.
Mm-hmm.
And now I coach some kids only one time per week, kids with let's say mental health issues. I mean, they are how to say this,
maybe intellectual disabilities or something like that.
Yes, intellectual disabilities, yeah. And I coach them 1 day per week, only pleasurable activities and games, and only this.
Okay. So and so have you ever had the opportunity instead to meet people with mental disorders different from intellectual disabilities?
Can you repeat, please?
Yes, I mean, so you told us that you have this experience with the kids with intellectual disabilities. I was wondering whether you have also experience with other kind of mental disorders. No, just intellectual disabilities.
No.
Okay.
Yes.
Okay. So now, so I guess that all the topics that we will cover in this lesson this afternoon, I hope will be interesting for you, because we will discuss about different mental disorders. So thank you, Alex, and thank you for joining us today and also in the next lessons. So the next one is Serbu Julian.
Hello.
Hello.
My name is Serbu Julian and I am a fitness instructor. I am a doctoral student and I teach physical education at the Faculty Psychical and Sport of Ovidus University in Constanța.
Okay.
That's it.
Okay. And have you ever had any experience with people with severe mental disorders?
Small experience.
Okay, which kind of experience? You know, I am just curious, just because I would really like to know each other, to create a sort of group of people that are sharing opinions. I don't want to be your teacher, let's say, but just a sort of expert, just because I am a doctor and I know I have some knowledge on mental health. But I really would like to know your experience, because you know the main aim of the project, of the EASM project, is just to try to create this connection between the world of professional working mental health and the world of people working in sport. So this is the reason why I am trying to collect so many information. Don't be shy.
I am a class coach, fitness aerobic.
Okay.
De 10 ani, 10 years. And I
okay.
Yeah, it's hard to me to express myself, but I understand what is being said.
Okay, don't worry. We will have time to discuss about these issues also in the next couple of hours. So now I see, I don't know how to pronounce your name, Ritu. Sorry, I'm sure that it is the wrong spelling.
No, yes, it's Reetu. Hello, my name is Reetu, and I'm from Finland, and my education is Bachelor of Social Service. And I work in Ilves, it's football club, and I work there as a supervisor of afternoon club. And I went this training because I believe sport can be a very effective factor with mental illness patients. So this training is very good new thing for me. And I have experience a little bit. I have done internship at school with mental illness patients.
Okay. And do you know also, when, if I understood correctly, you told us that you have a little bit of experience with people with mental disorders?
Yes.
Yeah. And so do you know also which kind of mental disorders these people were suffering from?
It's more like depression.
Okay.
Yes.
Okay, so because briefly we will discuss also about depression. So it is important to me to know that you have already a sort of rough idea of what is depression in the clinical practice. So, yes. Okay, so thank you, Reetu.
Yes. So guys, can I say something?
Yeah.
Reetu's club, this football club, is one of the biggest in Finland, so it's really nice that we have a coach from that.
Lovely. So Reetu doesn't underline this aspect. So we are very, very honored to have you here today. So I guess that for us as in Italy, if we had I don't know, someone from Juventus or this kind of major football club, so we are very, very happy to have you here this afternoon and also in the future lessons. Yes. So I guess that we can move on. The next person I see is Alejandro. We cannot hear you. Okay.
Okay. Hello. No, my problem is I never speak English. You know, so for me it's like Aspetta, one moment, perché sto parlando con Stefano al tempo stesso e mi blocco, mi è difficile. Aspetta un attimo. Ecco, adesso dopo rispondo Stefano. Ma it's possible to speak Italian? No, no.
Yes, if you prefer it, then I can translate.
Okay. I promise the next week speak English. I promise my task.
Okay.
Allora, no, che volevo scusare con loro perché per un fatto del rispetto, che però sto in un momento un po' complicato perché la mia madrelingua è spagnolo, studiando italiano e non parlo mai inglese, quindi mi era complicato.
Non preoccuparti.
E quindi ti dico a te veloce, se vuoi dopo provo a parlare con loro in inglese senza problemi.
Ok.
Allora, io lavoro nella Federazione Italiana del Rugby e la mia responsabilità è alleno il centro di formazione permanente, che è un lavoro elite, al centro di preparazione olimpica, che sono dei ragazzi che si preparano per fare nazionali, under 18, under 20, e poi sono formatore degli allenatori, quindi questo nella parte specifica dell'allenamento, e poi partecipo invece, questo a livello nazionale, e a livello regionale partecipo nei progetti di integrazione sociale che fa la mia federazione. E per quello sono stato, diciamo, molto interessato a partecipare a questo progetto. In questo momento sto facendo, io non ho esperienza, per quello che chiedevi agli altri, non ho esperienza specificamente con questo tipo, diciamo, di persone, però per esempio adesso attualmente sto facendo un progetto del rugby di inserimento in una casa famiglia, dove invece sì, ci stanno un po' di ragazzi, però loro vengono seguiti da specialisti, però comunque con il loro sostegno comunque li porto in campo, ci stiamo con loro, però è una cosa che ho iniziato un mese fa.
Okay, so okay, thank you, grazie Alejandro. And now, if you wish, I can try to translate a little bit the things that you told me. Okay, I can translate. Okay, so Alejandro is here from the Italian Rugby Federation, and he has these many roles in this federation, because he's also the trainer for other trainers, but also he is the trainer for athletes, and he is involved in many activities also from a social point of view. And he told me that he has never had a direct experience with people with mental disorders, but now he is working in a social project regarding the what in Italy we call the Casa Famiglia, that are a sort of protected shelter for people that have problems in their own family. And so it is a way to include them from a social point of view. So Alejandro is very sorry of not being very fluent in English, because although he lives in Italy, I guess in Rome or somewhere in the Lazio region, I think that you are from Spain, isn't it? Sei spagnolo, Alejandro?
Sì, anche I'm from Argentina.
Okay, Argentina, okay. So he's trying to learn Italian, and so English is another language. But we are very happy that you are here today. And then I see that we also have Sami.
Yes. Hello. Yeah, Komu is not for this. It's what I do in the daily. But my background is that I'm Nurse. I have worked in mental health sector like 4 years, 5 years, and I've played football 20 years, actually whole my life. Some of them quite professionally, but not professional. And mental health issues interest me a lot, and like human mindset, and how doing sports can reduce loneliness and get our touch to each other.
Okay.
That's me.
Thank you very much. I guess, I don't know if you told us, but I guess you are from Finland as well.
Yeah, I'm from Finland, yeah.
Okay, and so we are very happy to have you here this afternoon and also in this course. And I guess that now everybody has introduced themselves, and I don't know if someone else would like to add something or not. Maybe Stefano.
Yes, there is Lewis from Everton. He's another coach from Everton in the community, and he has.
Oh, sorry, Lewis, I can see you.
It's
So
okay. Yeah, so I'm Lewis from Everton, the community. I run a couple of our programs across all ages, from walking football to refugee football to health promotion. I have little experience working with mental health problems, and I'm looking forward to being able to identify and learn more about them.
So thank you very much. So I guess that you are based always in Liverpool. You are working in collaboration with Everton in the community as well, is it?
Yes.
Okay, lovely. And maybe I missed it, but have you ever had any direct experience in working with patients with severe mental disorders or not?
No, not really, no.
Okay, not really. Okay, brilliant. So I don't know if someone else would like to add something, or if we would like to move on. So in my mind, I have allocated more time for the part of introducing ourselves. But I guess that we were kind of very quick in doing this part. So please let me your thoughts if you would like already to have a break, or if we would like to go on and then have a break in a couple of, I don't know, in half an hour or something like that. What do you think?
I think later.
Later, okay, brilliant.
Yeah, I'm happy to carry on.
Okay. And before going on, I don't know if you have had the opportunity to fill in the questionnaire that Stefano sent to you by email. But if not, or even if you have already done it, I would like to do it again, just for a sort of activity for breaking the ice, let's say, because this questionnaire, and now I guess that you can see it. Give me a second. Yes, it's a sort of way for me to understand which are your opinions, let's say, about mental health problems more in general. And of course, here there are not right or wrong questions. It is just for creating a sort of discussion between us, among us, because I would like to explain you something. Can you vote or not? So, do you have the opportunity to vote or not? Because I am the host, so I cannot vote.
Yes. I can vote.
Ah, okay. Maybe you have to vote to all the questions, and then at the end, I can stop the poll, because now I don't see anybody have vote. Stefano, can you confirm me that you can vote?
Yes, I think everybody, no?
Maybe if you scroll down the list, there are in total 6 questions, and if you, okay, now I can start seeing some votes. If you vote to all the questions, at the end I will show you the results, let's say, just for understand what we think about mental disorders in general. Don't be shy, because this is very anonymous, so it is not a sort of evaluation questionnaire. It is just for me to have a different way to create a discussion between us. among us. So I have, okay, for people 5, because I have seen that we are 10. I guess now that everybody has voted. Okay. Now I guess you can see the results of this very quick poll. The first question, as you have read, is about the opportunity for people with mental health problems to have a paid employment. And here we have a sort of a very heterogeneous, I would say, responses, because we have someone that say that of course they can, they should have a paid employment, but also someone that say, okay, no, maybe not. Of course, which is the main consideration for me, that considering that I am a psychiatrist. So the main point is that, of course, the paid employment can be a sort of good goal to reach in life of a person with the mental health problems, but of course it depends on the state of the disorder. It depends on the of the specific phase of the disorder. But more in general, it is just to say that everybody has the potentiality, the capabilities to be rediscovered and to be fostered and to be implemented to allow them to have this capacity to have a paid employment. And then here we found that instead, if you see, can you see the second question? Not yet.
Yeah, I can see that.
Okay, now here in the second question, we almost, I would say all of us agree that if we had a friend with mental health problems, we will suggest them to go for a professional help. And although this question can be seen as a sort of obvious one, I can affirm you, and you should trust me, that when I have posed these questions to young people, to adolescents in high school, it was not so a striking result like the one that we have today, because many people are kind of frightened by the idea to go to mental health professionals, because they think that there is something strange, that so the psychiatrists or nurses or psychologists are just for people that have problems that should not be disclosed. So it is very important that today all the people that are here instead agree that the professional help is something that we should always use without any kind of preconception or kind of stereotype. And then we had this third question regarding medication. And of course, also here, we can see that the majority of people tell me that, so you agree that medications are important. And again, I am very happy to see these results, because later on in my slides, I will provide you with some very general information regarding medications, regarding also side effects, because of course, when you will be working in your daily practice with people with severe mental disorders, of course, medications can have some side effects. So although we know that they are very important to be prescribed to people, at the same time we should be aware of the kind of side effect that we can have. So it is really a good point that we all agree that medication can be useful. And then again, for psychotherapy, so the so-called talking therapy, again, all of you agree that these are very important strategies to be used. And again, I would say that this is not a quite obvious result, because, you know, some people think that talking therapy is not really a therapy. It is just like talking with a friend, but it is not really like that. It is something something very useful for our patients, and also with proven scientific effect on people receiving it. And then the idea also of the fully possibility to recover, and again you agree. So I really would say that maybe the last question is that we obtain the most different results, because regarding the idea that people with mental health problems go to healthcare professional for receiving professional help. And I would say that again, this is a very interesting result, because really I guess that it reflects the complexity of reality, and also the complexity of the fact that here there are people from Finland, from Romania, from UK, from Italy, and so in these different countries, of course, the organization of mental health care is different, and also the perception that people have towards mental health problems is different. And I would say that these responses reflect this kind of a different point of view. So thank you very much for having participated in this pool, because I really think that it has represented something that gives us the opportunity to enter in more detail in the topic that we will discuss today. And first of all, the first thing that I would like to discuss with you is what is mental health. But before providing you with a definition, I would like to ask you, how would you like to provide a definition by yourself? According to your opinion, what is mental health?
It's a state of well-being, let's say. I mean, I don't think it can be defined.
Mm-hmm.
And everybody would feel it different.
Okay, so if I understood correctly, you mean, Alex, that is a personal well-being, and is something that cannot be really defined. And I will say that from a certain point of view, I agree with you, because of course mental health is part of well-being. But of course the well-being is a very extensive concept. And of course, when I think about well-being, I of course think also about the physical health, but I think also about my quality of life. And there is only an aspect that I don't really share, I would say, with you. That is the fact that it cannot be defined. Because of course, this instead, I guess that it should be defined, it can be defined, but maybe the problem is that the way through which we can define mental health is more complex compared to other kind of condition. And here you can see I provide you with a definition, and as Alex said, mental health is a state of well-being. But of course, I would try to describe you in which sense is well-being. Then well-being is the capacity for an individual to realize his or her own abilities, but also it is the capacity to cope with stressor in daily life. It's the capacity to work productively and also to contribute effectively to the community. Of course, it is an integral part of health, and it is more than an absence of mental disorders. And of course, mental health, we know also that is influenced by several factors, not only physical ones, but also environmental, social factors, biological factors. And I guess that these very difficult times in which we are living from already 2 years on are really demonstrating to us that our mental health can be severely impacted from all these factors, and that we should think about how to improve our mental health. And the other concept that I would like to introduce you, it is also this: what are mental disorders? Again, have you?
Gaia, can I say a comment?
Yes, of course, Samsa, thank you for interrupting me. And also, if I speak so quickly, please give me, I don't know, something, because I can, sometimes I know that I have this problem. So please go ahead.
I was just thinking the definition of mental health, also that the social or cultural point of view, we have different definitions in different, probably in different societies and different cultures. Mm-hmm. Like who is mentally health or not. And also we have, of course, we have a medical definitions for disorders and stuff like that, but also that it changes through time and culture and in society, like who is mentally health, and then also individual point of view, how I myself, but just a comment to think about.
Yeah, no, that it is a very important comment, and I would also thank you first of all for this comment, also because I would like to add a thing that as I will show you in the next slides, of course the problem that there is so heterogeneity when we speak about of what is mental health, and so also what is mental disorders. Of course, this, according to me, one of the main complex aspect of this discipline that is psychiatry, because of course if you have I don't know, for example, fever, or if you have hypertension, it is really something that is a little bit easier to identify, because of course for hypertension it is the same range of values in Italy, in Finland, in the US, in the UK. But of course, as you were thinking about, for mental disorders and for mental health can be a little bit different because of cultural factors, social factors, and other environmental factors. But I would say also that us as a psychiatrist, of course, are aware of these differences. And for this reason, we, in particular, in our diagnostic systems, as I will show you in next slides, now we are starting to acknowledge these differences, including some specific factors that can consider all these diversity that should be acknowledged as a strength of this discipline and of this approach. So really, thank you for making this comment, because I guess that it enrich our discussion. So are there any other kind of comments or I don't know, ideas, suggestions, something that you would like to add?
I would like to add one thing. I'm trying to go exit from this webinar, but it sounds very interesting, so I need to stay here. So it's a very I'm very excited for the fact that now we are talking of mental health, and there is just one doctor and one psychiatrist, and we are all people that could be supported, that could out from the medical and psychiatric system. So it's very important. This is very good step for the improving form, because it's not different what is mental health, because mental health is always the same. How the different region, different environment approach to mental health and manage the mental health, because this is the real difference among Europe, that we don't have a unique system for treatment of mental health. There are some countries that open the psychiatry, that already open, that they still have open the
asylums, you mean?
Yeah, and there are some countries that okay, sometimes we have the experience with the national football team, Crazy for Football. We sometimes say that in some countries the guys are included in communities, in locked communities, locked, and in Italy sometimes the patients could dress the blue shirt of the national team. So it's the management also for mental health is important. But for me, very important that we are around a doctor, a psychiatric that could explain us what we can do for mental health system. Because I don't know what I can do for some patient that have a fever or has broken legs. I don't know what I can do, but I'm sure that for mental health system, the civil society could do a lot of things.
Mm-hmm. Yeah, thank you, Valerio. Thank you, Valerio, because I really think that you highlighted this very important issue, that is the fact that in this meeting today, it is true that I am the only psychiatrist, the only medical doctor, and I am trying to provide you with some let's say technical information, I hope in an easy way for understanding, also because you can really, this information can help you to do something in the society, as you told us before, because really the main thing that you can do is that having the correct information is to widespread the need for example, referral to healthcare professionals, to promptly go to doctors in case you have some symptoms that are related to mental health, and all of these aspects are in the field of course, challenging stigma of mental disorders, because of course, I guess that all the projects that use sport in the mental health field also have this very important aspect, that is a way for demonstrate to the general population that also people with severe mental disorders that for decades, that for centuries have been considered as the strange people, as people that can be dangerous, or people that should be apart from the civil society. Now we are telling them, okay, but see, this person, although has mental disorders, he or she can practice every kind of sport without any kind of difficulties, or maybe the difficulties can be present, but also for me, I am not really a sporty person, and if I decide tomorrow to start playing football, of course I will not succeed, but it is because I am not being trained in do so. And so this is the key message that we also would like to disseminate through this course, I guess. And so thank you, Valerio, for also pointing out this issue. I have seen in the chat that Samsa is going to leave the webinar, so thank you for the time that you dedicate to us this afternoon, and I hope that you will join us in one of the next sessions. And so if there are no other comments, I would move on the next slide. That is on what are mental disorders. And I don't know if you would like to provide me with a possible answer. So, mental disorder is a syndrome characterized by clinical significant disturbance in several aspects, in several areas of individual functioning, that is cognition, that is emotional regulation, that is behavior. And of course, all these alterations have an impact on the quality of life, but also on the personal functioning of the people in his or her daily life. And so this is the reason why mental disorders are usually associated with a high burden, both on the personal level, both on a societal level, because of course the people with severe mental disorders need to be supported by family members, by caregivers, by society in general. And so this is the reason why it is important to know what is mental disorder. And of course, the other aspect that I would like to highlight to you is that mental disorder are the diseases like any other kind of disease in our body, and although it is again, it seems quite obvious, I would say again that it is not really like that, because for many years people affected by severe mental disorders have been considered as affected by disorders that we are not really sure if they exist or not, or disorders that can be dangerous for the society, and so on. And so now it is the time instead to be sure and to disseminate this correct information that mental disorders are really like all other kind of disorder. And
una domanda,
sì.
ma l'aspetto biologico è inteso come, diciamo, genetico personale o biologico? Non so se...
See, okay, so Alejandro asked me if the biological aspect is related to genetics or also to some other issues. I will say that, of course, genetic plays a role in the development of mental disorders. But again, considering that mental disorders are complex disorders, of course, we have not had the opportunity, the capacity to identify a gene, specific gene that can code or can predispose to the development of depression or schizophrenia or any other kind of mental disorders. Of course, now the most widespread concept is that there are many genes, many loci that predispose people to develop mental disorders. They are a sort of risk factors, but of course, they are not enough for developing a mental disorder. So of course, there is the need also for other elements to develop the disorder. Of course, here the question would be, okay, so do you already know which are the risk factor, the exact risk factor for developing a mental disorder? Again, here we have some hypotheses, but we have not yet identified factors that necessarily must be present for developing the disorder. Because today the idea is that mental disorders are multi-determinate disorders in which biological but also psychosocial elements should concur in the definition of the disorder. For example, I don't know also if in your countries there has been this kind of discussion, but in my mind came the discussion regarding the use of cannabis, the legalization of cannabis. Of course, the problem in the issue is a very big issue, but why? Because of course we have some studies that have proven the fact that people using cannabis are at high risk to develop, for example, psychosis. But why some people that all in the same way use cannabis did not develop psychosis? So probably here the reason is that it is not the cannabis alone the risk factor, but it's the cannabis use together with some personal risk factor that I already have, and it is the interaction among these factors that define the onset of the disorder. So it is just a very small, a very simple example, just for trying to explain you how complex are mental disorders. And so also this is the reason why we have tried to put a lot of information in these training sessions for giving you a very general idea of the complexity of mental disorder, and also for giving you some practical tips on how to interact with people suffering from these kind of disorders. And I don't know, are there any other comments or suggestions, ideas?
Okay, thank you.
You're welcome. So I was just telling you that mental disorders are, of course, categorized and classified, and how. We use mainly these two kind of classification system. The one developed by the American Psychiatric Association, maybe you have heard about the DSM, which is the Diagnostic and Statistic Manual for Mental Disorders. Actually, we have the fifth version, but in the next couple of days, they will release a new revised version. And then we have the International Classification of Diseases, the ICD, which is developed by the World Health Organization. That is the most frequently used classification system adopted by healthcare systems worldwide. And these two systems are similar from a certain point of view, but of course they have also some differences. Of course, here I would just like to give you a very provide you a sort of overview on this diagnostic and the classification system, just highlighting that the main point in common is that both systems have a categorical approach. But what does it mean, a categorical approach? A categorical approach means that for formulating a specific diagnosis of a mental disorder, we need that some specific criteria are fulfilled. Of course, it is a very straightforward way for formulate diagnosing. And of course, this is the reason why these systems are widely used in worldwide. But why I am dedicating so much attention to this aspect? Because of course, we as a psychiatrists know that we deal with people, with persons, with patients, and not with diagnosis. And so sometimes we see that the boundaries between a disorder and another disorder is not so clear, like in the classification system is depicted. And so this is the reason why we sometimes also need a sort of dimensional approach, it is called. But of course, also psychiatrists needs this kind of categorical approach, because this is the approach that is usually used in all the field of medicine. Because of course, maybe here there is an example: a patient has or does not have pneumonia or a cancer or diabetes and so on. But of course, with mental disorders, the boundary between normality and the presence of a disorder is much more complex. And so this is the reason why we need this dimension. This dimensional approach can be useful to describe the complexity of mental disorders, and also can give us the opportunity to identify in the person the presence of different symptoms, regardless the specific diagnostic category. And I guess that this is important for you to have, because in our idea, this training that you will, these pilot actions that you will have to do to perform at the end of this training program would be useful also to have a sort of collaboration or discussion with, for example, psychiatrists or any other kind of medical doctors. And so sometimes you will listen them talk about this kind of different dimensions. And so we thought that it is important for you to know that also this kind of approach is present, not just one that people are presented to you, okay, he is affected by schizophrenia or she's affected by bipolar disorders. There can be also different dimensions that overlap, and of course the clinical presentation becomes more complex, but at the same time I would say that this is probably the most complex, difficult, but also interesting part of our work as psychiatrists and mental health professionals. And there are several mental disorders, and of course we don't have the time, and we don't it cannot be affordable to discuss all mental disorders, and so we decided together with the ECOS team to select the most severe mental disorders, and also to discuss about you with these three groups of disorders that are schizophrenia and psychotic disorders, depressive disorders and bipolar disorders, because these are disorders defined as severe in general in the field of medicine. These are defined as severe mental disorders, but just for letting you know, of course we have other disorders like, for example, anxiety disorder, obsessive compulsive disorder, or PTSD and trauma related disorder, eating and feeding disorders, and so on. But again, we decided to introduce you just these three categories of disorders, because in our experience, and also with the experience of the SPEAR project, the people that most frequently take part to these activities are people suffering from this kind of disorders. And so, first of all, I will introduce you the schizophrenia. Do you have an idea? Do you know what is schizophrenia?
I have in my class, I have a boy around 20 years old.
Okay.
And we're practicing and we're doing exercises, and all of a sudden he stops and he starts talking.
Uh-huh.
Yeah, and he's not paying attention. He's looking in some other places and he starts talking, and I just snap at him, and he's trying to pay attention to me after this. And I think this is a form of schizophrenia.
So Alex, can you repeat, because I am not sure I understood correctly. So this is a young boy, 20 years old, more or less. And yes. What you have seen, that he suddenly stopped to speak?
We are playing with the ball, or we do our exercises, yes. Okay. And all of a sudden he's looking in some other direction, and he's mumbling something. He's
okay. See,
he's talking very, very, very slowly in some other direction.
Okay, I see.
I think this is a form of schizophrenia. I mean, it's when you hear things or see things that are not over there.
Mm-hmm. Yeah, you're right. Probably this young boy could be affected by schizophrenia, because these symptoms that you are describing as are the ones that we call hallucinations. Because probably seeing him that suddenly look at a very different point, start saying something, it is probably that he should have some auditory hallucinations. And so he may be urged to reply to these voices that he is listening. But as you can see here from this picture, schizophrenia is a very complex disorder, because you don't only have hallucinations that are the ones that now Alex described to us, but you should have also delusions, where the delusions are the beliefs that there is, for example, a plan against you. There are old people are deciding to hurt you, and they have developed a plan for damage you. And but any other kinds of also symptoms can be present, like the reduced speech, lack of initiatives, affect that can be flattened, or the speech that cannot be easily followed by people that are listening to you. And so this is just for explain you how complex, how also difficult can be for patients and painful also is for patients managing schizophrenia. And for all these symptoms, you can also imagine how can be difficult for them to be engaged in any kind of activities, in particular also with any kind of sport activities, because of course you can as you already know from your professional experience, of course, in performing physical activity, sport activity, of course, motivation is the very first element that always should be present. And in patients with schizophrenia, because of part of symptoms that are present, as you can see here, lack of initiatives represents itself a predominant symptoms of schizophrenia disorder. And so this is for highlighting to you can be difficult to involve people with this kind of disorder. And here I have summarized for you the main essential feature of schizophrenia. And as we already described, there can be positive symptoms like hallucinations and delusions, but also negative ones like lack of motivation, lack of desire for starting to do things, but also disorganized symptoms. So we can see people that are not able to decide which kind of clothes to wear, or maybe using clothes that are not appropriate for the weather. And finally, another very important area that can be impaired is the one related on cognition. And why it is important? Because when I talk about cognition, I also talk about the capacity of attention. As now that I am talking with you, at least from 1 hour and a half, more or less, of course, I hope that you are trying to follow my English and also the contents that I am introducing you. And of course, you are trying to be to follow me, and the attention is present. So this kind of exercise, and the one we are doing today, is I would say probably not possible to be done by patients with schizophrenia, because this area related to cognitive function is very frequently impaired. And
il sintomo è positivo e negativo.
Mm-hmm.
Sono insieme o possono essere uno o gli altri? Perché forse mi sono perso io.
No. Thank you, Alejandro. Alejandro was asking me if these symptoms that I called positive and negative are some symptoms that should be present, the positive, but not the negative, or vice versa. It is not like that. It is like people can have simultaneously these symptoms, so they can have, for example, auditory hallucination, but at the same time they are not able to, they have this reduced speech, because of course they are just closed in their thoughts and are not able to communicate with other people, and can have this lack of attention or lack of interest in start doing things. So both these dimensions, it is a sort of oversimplification that I have used for trying to be more clear in the description. Okay, but another example that I usually do for trying to imagine what is schizophrenia, I don't know, probably you know the movie called A Beautiful Mind, in which the main character is John Nash. Then John Nash has been a Nobel Prize for maths, if I remember correctly, and he suffered from schizophrenia. And in main part of the movie, you can see that he is speaking with the two men, but just at the end of the movie, we as people understand that these two men were not real, but are part of his delusion, because they are hallucination to which he is continuously speaking and discussing.
Che queste tipo c'erano come un staccamento dell'individuo dalla realtà, vero?
Esatto, yes.
Etimologia della parola greca, me ricordo della scuola.
Yeah. Alejandro is telling me that the word schizophrenia comes from the Greek etymology, and it is a sort of detachment from reality. Yeah.
Okay. Thank you.
You're welcome. Thank you for your question. And now I guess that according to the original program, now we were supposed to have a 15-minute break for a cup of coffee or tea, or just, I don't know, to stretch our leg. So if you like, we can stop a little bit and then continue, or not, as you prefer.
I don't mind if we continue.
Okay. Okay, so the next disorder, let's say, that I would like to introduce you is depression. And maybe depression, I would say, is something that I don't know. What do you think is depression, depressive disorder? Do you have any idea? Have you someone, maybe if I don't remember, if I remember correctly, someone told me that have had an experience with people with depression. So
I think it's their ability to do normal stuff like wash your teeth and eat, make food and something like that. It's very hard, and they don't have strength to maybe do these things. Example.
Yeah, thank you, Retu. I guess that you exactly highlight the main aspect of depression, because when people are depressed, the main thing is that this is a very impairing disorder, because people are not able to carry on their usual activities. They are like unable to do anything. They are not able to take care of themselves. They are very tired. They can sleep a lot during the day, also during the night. And of course, they have this very low mood that is the main characteristic. Of course, they can start crying suddenly, but also they can have this suicidal, for example, ideation. But of course, difficulties also in concentrating. All of these aspects are different, I would say, different aspects of depression. And again, this is the reason why depression is, again, a very complex disorder, because we can also see people, as I have reported here in the vignette, also agitation can be an expression, a symptom that we can find in depression, also because people can feel like very, very tense, very, very angry also sometimes, and are not able to express this feeling. And if we then analyze in more detail this aspect, then we understand that they really are depressed. So and depression again is a very, very is a severe mental disorder because the impact on personal functioning is very relevant, because people, as I already told you, are not able to work, are not able to take care of themselves or their family members, are not able to do anything, neither leisure activities. And furthermore, when we think about depression, another aspect is that it is a very common mental disorders. Consider that in Europe, there are at least 300 million of people suffering from depression. So these are very huge number of people. And the other aspect is that people with this kind of disorder, in many cases, are frightened, are worried about this disorder, and try to not disclose the presence of the disorder. And so, for example, considering that people with major depression are usually people in middle age, and so they represent the vast majority of working people. Another very frequent aspect is that they continue to try to go to work, but they are not productive anymore. And so there is another big issue that is the so-called presenteeism, because people are at work, but they are not productive at all. And so basically they are not taking care of themselves, but are neither doing their work. And so it is just a vicious circle from which we should try to help them to break it and to ask for help and to try to get the appropriate treatment.
It can be
okay, Alex.
It can be similar with the lack of self-esteem. It's the same.
Yeah, I would say the lack of self-esteem is one of the symptoms that we can find in depression, because of course people have also this depressed mood that is the main aspect, to which it is associated also the lack of self-esteem, the feels of hopelessness, of emptiness, and also that my life is not worth to be lived anymore. So of course also self-esteem is a very important issue. So thank you, Alex. Alejandro.
No, volevo chiedere se diciamo entrare in uno stato di non so se è corretto come termine, però uno stato diciamo di disordine di depressione si può essere causato diciamo da un episodio, di un qualcosa, o come i fattori che abbiamo parlato prima, oppure che si evolve nel tempo, perché per esempio mi è successo di una persona vicina, stavo parlando spagnolo, poi stavo facendo un casino tra le tre, un mio ex compagno di squadra che ci ho giocato quasi 11 anni insieme, quando abbiamo smesso di giocare lui è entrato in questo, subito dopo si è allontanato dal club, chiuso in casa e soltanto per sapere come poteva funzionare questa cosa.
Okay, so thank you, Alejandro. So Alejandro asked me if there are a sort of any kind of risk factors for the development of a major depressive disorder, and even if there can be any kind of traumatic event or any other kind of event that can be considered as a cause for a depressive episode. I would say that probably yes, there can be some events in our life that can be considered as traumatic. But when I say traumatic, what I mean that, for example, deciding to change my sport club, or deciding to be retired from my sport activity is is a very life-change decision, because all my life must change from that point on. And if I'm not able to find any other kind of activity or any other kind of things that can motivate myself, of course, this can be a sort of precipitating event for developing a depressive episode. Of course, I don't know the exact case of your friend that you were describing me, but of course it can be also that on the other side, he decided to leave the club because he felt that something wrong was going on with him, and so he decided to go away before the other people can start to understand that something was changing. But in any case, the main issue that you pointed out is that really also the normal, the usual things that happens in our life can represent things that can be a sort of stressor for us, and everybody has different levels of resilience, let's say, so of cope capacity with these stressors. So thank you for this, for sharing with us this experience. It's really important for us, and I guess really relevant for this kind of discussion that we are having. Just a moment. Okay. Any other comments? So the last, let's say, disorder that I would like to introduce you is the bipolar disorder. And do you know what is bipolar disorder, first of all? What came in your mind when I say bipolar?
It is when you have seasons when you go really fast, and the seasons when you are depressed, and also there are seasons then when you are like not depressed and you're not going really fast.
Mm-hmm. So basically, you highlighted the main aspect of bipolar disorder. First of all, that is an episodic disorder in which there is this continuous shift between two phases, let's say, that are called manic or hypomanic phase, that are roughly characterized by symptoms, as Sami told us, let's say, very fast in speech, and then talkativeness, becoming easily distracted, and so on. But at the same time, these episodes can be interrupted, and we can have these depressive episode once. And so it is the alternation between these two phases that is very challenging for people, because of course patients are struggling in trying to find a balance between these two phases, but it would be necessary sometimes several years before finding this balance among these two different phases. And again, here you can see that I have choose this figure because according to me was a sort of very impressive, because it summarized the two aspects that can be present in people with bipolar disorder. So they can have these manic phases in which the mood is elevated, expansive, irritable, the speech is very rapid. There can be also delusion of grandiosity, or hyperactivity, reduction in need for sleep, flight of ideas. So the tendency to do several things all together. Also, you can see here that in the picture, also the way of choosing clothes was very different. Here, flowers, stripes, very shocking colors, while in the depressive phase, the people start not to take care of herself. The clothes are not so important. There can be a reduction in libido, for example. There can be, I don't know, also suicidal ideation and so on. But some facts that I would like to highlight to you is that bipolar disorder is a very common disorder, is a very disabling illness, and also it is associated with a high level of mortality, also because people tend to have a higher rate of suicide, maybe due to the fact that the switch between one phase to another phase represent a risk factor for this suicidal ideation. And so it requires also an adequate timely treatment. But a very also fun fact is that bipolar disorder is usually associated with creativity. And now I show you that there are a lot of famous people that have been diagnosed, that have received a diagnosis of bipolar disorders, ranging from painters, famous painters like Vincent van Gogh, to most recent football player like Maradona.
Two Argentines, Diego Armando Maradona e Christian Pitti Alvarez, the artist Argentina, due.
So maybe the question is there in Argentina a specific risk factor for bipolar disorder? Or
I don't know.
I don't think so.
No, I promise my last question.
No, please go ahead, Alejandro.
No, la domanda era, perché mi sia difficile fare veloce, la domanda è in quale arco temporale si devono verificare questi cambiamenti per essere considerato, diciamo, dentro questo aspetto? Nel senso che non lo so se è chiara la domanda.
Yes. So thank you, Alejandro, for pointing out another very relevant aspect. So Alejandro asked me regarding the diagnosis of bipolar disorder. I told you that we need to have the switch between a manic phase to a depressive phase. But of course, there is, Alejandro was asking me for a temporal requirement. The diagnostic system told us that for formulating the diagnosis of bipolar disorder, we need to have at least 5 days of a manic episode, and that's it sufficient to formulate the diagnosis of bipolar disorder. In other words, we do not need to see both phases at the same time. Of course, it can happen, but it is a very rare, a complex situation that we call mixed states. So very specific and specialistic issue. So don't worry about that. But in general, the thing is that these are people that have this phase of grandiosity, of hyperactivity, or reduction in the need for sleep. And it, I don't know, for example, can last 1 week, 2 weeks, maybe also 1 month. But at a certain point, this ends, and then it comes the depressive phase. And it is this, sometimes we see a sort of very slow decrease of the mood from the manic or hypomanic to the depressive one. And of course, it is this switch is not like turning on off the light. It's something more gradual, but at the same time, it's very painful for the patient, because of course the patient can spend, I don't know, weeks or months in this depressive phase without no interest for anything, and then day by day can find again the vital energy, but at a certain point this becomes too much. And so the problem with these patients is of course that they are not really aware of the manic phase, because of course when you are manic, you are happy, let's say, you are able to do a lot of things, you are full of energy, you would like to do everything comes in your mind. But of course it can be also dangerous, because these are also people that can engage in some risky behavior. And in fact, in our clinical practice as a doctor, it is very much frequent to see people when they are depressed. And then when we collect information regarding their story, we understand, we discover that probably it is not just a depressive episode, but it is something more complex in a bipolar disorder. So this is the difficulty for us as psychiatrists to deal with people with bipolar disorder, because of course the alternation of these two phases is is challenging for patients, and of course is challenging for us, and there's also some implication from practical point of view, from the type of prescription that we have to do to these patients. Okay, I have a reply to your question. Okay. And here, just for summarizing, but again, this is a very, very specific and medical, I would say, aspect that from a classification point of view, we identify bipolar 1 disorder, bipolar 2 disorder, and cyclothymic disorder. But again, this is just for give you an idea that, again, the complexity of mental disorders is huge, and that in the global definition of bipolar disorders, there is a variety of disorders that are included. Okay. And again, the need for having another slide on many hypomanic episodes is because these represent really the most difficult part of the disorder to be managed. Because as I already told you, during a manic episode, people are feels that they are very full of energy. But also they can be irritable, dysphoric. They can have this exaggerated sense of well-being. They have a reduced need for sleep. But of course, why this is important? Because again, if you are doing a sport activity in a group, having a patient that is experiencing a hypomanic or also a manic episode, of course, will be very difficult to manage in a group, because of course this will be the person that would like to do all the activities and just the only one to do it, and the people that catalyze all the attention from the group, and so it can be very challenging also for you. So this is the reason why it is important to speak about that. So now I have some case vignette regarding these disorders, and but before going through these, I would like to ask you if you have any other questions. No? No? Okay, so the first case is the one on regarding Marina. Marina is a 30 years old woman referred to the mental health clinic by her caregiver. And the caregiver described the fact that Marina behaviors has changed in the last months, because she had this sudden disruption of the relationship with her fiancé, and she became agitated and afraid, uncomfortable with anybody other than the caregiver. And so, but in particular, they reported that Marina starting to steal without moving for several hours. And Marina was very cautious when she met us as doctors. She tried not to look at in our eyes, and we noticed that during the clinical interview, she started to jump from a topic to another topic, was not able to focus on the specific aspect that we were interested in evaluate, and she was also sometimes very agitated. But at a certain point of the interview, she admitted to hearing some voices that tell her that people want to harm her. So probably these are some hallucinations. that are part of probably a paranoid delusion. And so when she has tried to describe this voice to the caregiver, the caregiver doesn't trust her and started to teasing her. And also she, due to the presence of these voices, she tried to took her life because she felt overwhelmed by these voices. And so of course, here so Marina, during also our interview, had some moments in which she wasn't able to move, and but at the same time, so when we asked her why this happened, she also says that she felt very, very anxious, very agitated with an inner tension. And she also said that when she was out of her home, she felt very unsafe and uncomfortable. And so for this reason, she preferred to stay at home, to stay alone, and to interrupt all the activities. So this is, I would say, probably a complex clinical case, but this is the idea is that Marina probably is affected by schizophrenia, and currently she is symptomatic because, as I explained you, she had the hallucinations, she has the delusion, but she has also this disorganized speech because she was not able to focus on something when we speak together, but also she has these behaviors that was very socially retired. So there are many symptoms present there that summarize again the complexity of schizophrenia. Do you have any, I don't know, question, curiosity regarding this vignette? Okay, so I guess that in total I have prepared 3 case vignettes, so I can we can have these 3 vignettes, and then I would ask, I would propose a break, a 10-minute break, and then we will have the second part of the meeting, and then if possible, and if you agree, I guess that we will have the opportunity also to finish a little bit earlier if we cover all the parts that are expected to be covered. Okay. Okay, so we have Luca. Luca is a 15-year-old engineer that decided to come to our department because of intense feelings of despair, and she felt without energy, and she was very, very sad, also because he told us that 5 months earlier he lost his wife in a car accident, and he described has this feeling of lethargy, of tiredness started after that event. So again, as in the question that Alejandro earlier told me, again, also here you can see that there is a major life event that probably has had a role in the onset of the disorder. But of course, it is not enough to have to being exposed to a very negative event for developing the disorder. Of course, there is also the need for some specific other risk factor. And so when we continuing the interview with Luca, he told us that decided to take some day off from work since the death of his wife, and he felt very low during the last months, and he describes himself as a very enthusiastic person, a person that would like to stay with other people and to spend time together, while over the past month he stopped all these activities. He didn't want to see anyone, and also he has 2 grandchildren, but he wouldn't like to meet them. because he felt not very well. And also Luca, now when he tried to meet people, he felt like useless all these encounters, because she was not able to stay in a conversation. Also the attempts by his friends to be in contact with him, to understand how things were going, for him were useless, because he was able to recognize that they have good intentions, but at the same time he felt that it was not useful for them to have this kind of interaction. And so Luca's productivity at work, as I already told you before, when you are suffering from the mental disorders like these, dropped in the last months. He had very many difficulties in concentrating. He was not interested in doing anything, and also he has difficulty in sleeping. With several wakes during the night, and he was not able to get refreshed from sleep. And so probably Luca was affected by a depressive episode, probably a very severe episode, because of course, as I already told you, he was not able to work, he didn't want to meet people, he was able to take care of himself, but there were no psychotic symptoms like delusions, like hallucinations. And I don't know if you have any curiosity about this clinical vignette or any kind of question. Okay, and then we have the last one case vignette, that is the case of Marco. So Marco came to our department saying that 2 weeks ago, he started to feel much more energy than normal. He suddenly informed his sister that he was planning a trip to an exotic island. And the reason why he decided to take this trip was that in that island, he would take pictures of rare birds and bring them back to sell them to journals. And of course, when the sister heard this decision, was a little bit worried, because said, okay, but you look that this is a very expensive trip. You are not a photographer, so why you should afford these expenses? And so when the girl started to try to change the idea of Marco, he started to become very irritable and refused to talk with her any further. And during the past 2 weeks, he has gone also to the bars 3 or 4 times a week, because very much enjoying to talking with girls there, and to also start possibly sexual relationship with them. And consider that usually Marco's behavior is not like that. Usually he doesn't like to go to the bar. Usually he is a person that loves to stay at home, and he's nice to have never used any drugs. But when we asked him, but why you are now doing all these things, he just stated that, okay, because now I feel that I feel happy, and I feel that I would like to celebrate. And so this is the reason why I am doing like that. And so this is a very, very simplified example, but probably Marco is suffering from a manic episode. And because you see that also this was a sort of very different way of behave compared to his normal activity. And so this is also another aspect that we should consider when make a diagnosis of this kind of disorder. And so now I am going in the second part of the meeting, and I would propose to have just a 10 minutes break, because I need to rest for my voice, and then we will be back in 10 minutes. Okay.
Okay.
You all at 4 p.m. Okay.
Okay, so as I already told you before, all mental disorders are associated with high levels of personal and social burden. And here in this picture, you can see that when we look at neuropsychiatric disorders, let's say including affective disorder like depression, schizophrenia, bipolar disorder, as you can see here, the vast majority of burden is related to this disorder. And why this is possible? Because as I've tried to explain to you earlier, these are disorders which have a very significant impact on level of functioning of people, because people due to depression, for example, are not able to work. And of course, being not able to work means that you will need someone else that will take care of you from a practical, but also from a personal, let's say, point of view. And so this is the reason why the burden is very high. And in particular, it is also been evaluated that people with severe mental disorders have the highest rate of disability adjusted life years. And this is because these mental disorders usually have their onset during early adulthood. The majority of these disorders have an onset between 15 and 25 years old. And so when people are in the living the phase of their life in which they are expected to I don't know, to define what to become in adult life, it is a phase of their life in which instead the disorder came. And so this is the reason why the burden is so very high. And furthermore, in order to provide you with a global and comprehensive picture of mental disorders, we decided also to provide you with some very general information regarding the treatment strategies for patients with severe mental disorders. First of all, I would like to say that we as doctors, as psychiatrists, do not work alone, but usually people with severe mental disorders are in charge to a multidisciplinary team in which we have also psychologists, psychotherapists, nurses, sociologists, social workers, and also in Italy we have this special healthcare profession that is the technician for psychiatric rehabilitation. That is a person specialized in providing specific psychosocial intervention for people with severe mental disorders. And so why it is important to underline this aspect? It is important because it confirms furthermore the need for having different people involved in management plan of a person with severe mental disorders, because these are complex disorders, and so a complex disorder needs, of course, a complex treatment in order to be really managed in a proper way. And of course, the management plan is personalized on the need of each individual patient and is also tailored to their needs. And of course, we will have in this multidimensional approach for simplicity, I will discuss with you two main approaches, the pharmacological ones and the non-pharmacological ones. When I think about I will speak with you with some pharmacological treatments. Do you have any ideas of which are the most frequently medications used by psychiatrists for treating people with mental disorders? So we have anxiolytics, benzodiazepines, like lorazepam, diazepam, like the so-called Valium in Italy. And then we will see also some commercial names of these drugs. Maybe they can be more familiar to you that you can think. Then we have antidepressants like escitalopram, like Prozac. Maybe you have heard about Prozac. And mood stabilizer like lithium, like valproic acid or oxcarbazepine. And then we have antipsychotic medications like haloperidol, risperidone, aripiprazole. For example, haloperidol is Haldol. And now, again, why it is important to speak about medications? Of course, not because you will become an expert in medication, or why because you will be able to decide which kind of medication each patient is using. But just because, as I already told you, medications, of course, like every kind of medication can have also some side effects, and some of these side effects can can interfere with the general global functioning of people. And so it is important for you, that will be the person in charge for developing these personalized project based on sport activity, to know that these drugs can have also any side effect. But first of all, why we use benzodiazepine? We use these drugs because they have a function as sedative, as hypnotics, as also as anxiolytic, anticonvulsivant. So the use of these drugs is in a wide range of situations for people with severe mental disorders. Furthermore, these are very safe drugs, very effective drugs. But the main issue when using these drugs is that there can be a risk for developing a sort of dependence and also tolerability. And so people need increased dosage of these drugs in order to get the same effect. So this is the reason why these are medications that should be properly managed by medical doctors. And here are some brand names that probably are more easy for you to understand which drugs I am referring to, like Xanax, like Valium, like Alchon, like Librium, and many other drugs we can have. But in particular, I am interested in sharing with you these side effects because, as I already told you, these are side effects that can be an important limit also for performing physical activities, because as you can see here, the most frequent adverse reactions include lethargy, apathy, confusion, or also drowsiness, sedation. Of course, for example, if I think about playing rugby, as Alejandro usually teach, of course, it would be, I would say, probably very difficult to play rugby if you are a sort of sedated, because of course you are not able to keep the ball or take a run and do things like that. So, but at the same time, of course, sometimes we patients are in need for this medication, so we have to prescribe it to them. But of course, we can modulate the dosage of these drugs. And for example, I know that previous experiences in sport activities in patients with severe mental disorders at the end have also found that people at the end of these activities feels better, because of course you can teach me how sport is important for improving your self-esteem, for improving your the level of satisfaction with your life, and also with reduced tension, and also improving the social interaction. And so for all these effects, in many cases, we also have seen that people requires a low dosage of benzodiazepines. So it is really very important to know it, because of course it represents another reason why it is important to promote sport activity intervention in people with severe mental disorders. Then we have antidepressants, which represent a heterogeneous class of medication. And from a very rigorous point of view here, I have reported the different pharmacological names. Again, here I don't want you to be so skilled in recognize if a molecule is an SSRI or a tricyclic, but just for give you an idea, as complex as different can be the type of drug that we can use in patients. Again, here we have some drug names, commercial name like Paxil, Zoloft, Cymbalta, Effexor, and I told you Prozac, one of the first antidepressants developed during 80s, and they have also different dosage according to the severity of the clinical case. And again, also antidepressants can have long-term side effects. The most frequent are sexual problems, weight gain, and also emotional numb. So you feel like detached from reality, not able to feel the things in a proper way, or sort of paradoxical elements reduce the positive feelings. But again, the most important ones that are important in our activity, taking in mind the fact that we will perform this sport activity, are related, according to me, to the weight gain. But again, of course, as I already shown you, we have different molecules which have different profile also in terms of side effect, and so we can have we can select antidepressants that have a reduced effect on, for example, weight gain. Then another category of medication very important is the one of mood stabilizers that are very important for people with bipolar disorder. And in this class we have the lithium, that is the most important one, because it is a very effective drug, but also other mood stabilizer include anticonvulsivant medication like valproic acid, carbamazepine, and so on and so forth. And again, also these drugs have some side effect that ranges from headache, nausea, drowsiness, but also, for example, in case of lithium, tremors, or for valproate joint pain, or for lamotrigine, loss of balance or coordination. Again, why it is important to know all of these? Because in general, if you we hope that during your practical activity, in which you are required to develop this sport-based intervention with patients with severe mental disorders, I guess that it should be important for you also to know if which kind of disorder the patient is suffering from, and also if he or she is taking any medication and which kind of medication, because of course for each of these medications you can expect a different profile of side effect. And so just for having a clear picture of the person that you are expecting to work with. And then the last class of medication is that of antipsychotic medication. The antipsychotics are usually prescribed to patients with schizophrenia or psychosis spectrum disorder. Also in this class we have plenty of molecules that, just for let you know, usually we as a doctor define them into big classes called typical and atypical medications. And the main difference is that in particular atypical medication tends to have more effects in terms of metabolic profiles, while the typical ones, which are the oldest antipsychotic medication, tend to have more movement and Parkinson-like effects. And here are just some drug names like haloperidol or like risperidone, olanzapine, and so on. And here again, it is just to explain you that these are the most frequent names of drugs. These are the molecules from a pharmacological point of view. And here are the most frequent side effects. And of course, here you can see that the profile is completely different because, for example, quetiapine or olanzapine have a very high risk of give sedation. While, for example, if the patient is taking aripiprazole, the risk for sedation is much lower. And so this is important for this reason, again, to know these differences, or at least to have in some part of your mind the idea that a difference exists. And now we are moving to the last part of this session, of today's session, that is related to non-pharmacological treatment, because although I'm sure I am aware of the role that pharmacological treatment have for the recovery of people with severe mental disorders, I am aware also of the fact that pharmacological treatment alone are not enough, because the recovery from a mental disorder is a very complex and long journey. And so we need a complex and different intervention. And when we think about non-pharmacological intervention, first of all, in our mind came the so-called psychotherapists that, as I already explained you at the beginning of this session, are the so-called talking therapies. Of course, we have a plenty of different approaches as regards psychotherapies. The most frequent, most common, the most known approach in psychotherapy is the cognitive behavioral therapy, but we have many other kind of approaches. Probably you have heard about a very influential psychoanalyst that is called Sigmund Freud, who lived at the beginning of last century, that was the father of psychoanalysis. But today we have developed many other approaches, many also counseling approaches in primary care, or also mindfulness-based approach, behavioral activation, and also self-help therapies, in which the trainer, let's say it's a user with his or her personal experience that wants to share his experience to other people, and then can provide so this kind of information. But why it is important to speak about all these elements that are not pharmacological intervention? Because, as I told you before, we have this part of psychiatry that is called psychiatric rehabilitation. That was a part of our discipline that it is a little bit more recent, because as you can see here in this article that I have brought to your attention, it is dated at the end of 80s, in which for the first time it was defined the concept of psychiatric rehabilitation. And why it was possible to define this concept? Because, as Valerio told at the beginning of this session, the psychiatric care worldwide has been for many decades based on asylums that now in Italy have been closed almost 45 years ago. And now the care is based on a community approach. And this has been possible because we have changed our basic idea. That is that from a severe mental disorders, everybody can recover, or at least everybody can have the opportunity to obtain treatment, to receive treatment in order to reduce symptoms, reduce distress, and try to live a satisfactory life. And so for all these aims, psychiatric rehabilitation plays a central role. And when I speak about psychiatric rehabilitation, I speak of a very heterogeneous and wide field of psychiatry, because these are the field that include, it's called psychosocial intervention, that include many kind of intervention. I don't know if you ever heard about this intervention that here in this table have been summarized, like for example the social skill trainings, the cognitive remediation, the cognitive behavioral therapy for psychosis. But I would like to capture your attention to one point, that here in this table that is derived from a scientific article published 3 years ago, more or less. Here you can see that these two men are two psychiatrists, professor of psychiatry in northern Italy, and doing a review. So it is sort of a summary of all the available evidences on treatment for people with severe mental disorders. And then they put also physical aerobic exercise among the evidence-based intervention for psychiatric rehabilitation of people with severe mental disorders. So I guess that this is a very important and relevant issue, because if today we are here starting a training course aiming to improve the kind of activity or sport-based activities that can be offered to people with severe mental disorders, is because we as a psychiatrists became more aware of the role that sport and physical activity in general can have for people with severe mental disorder. And please trust me when I say that it is not so obvious that this was going to happen, because it is related to the fact that we are witnessing a shift in the way we are treating our patients, because we are trying to use all the strategies we have in order to improve the recovery, the quality of life, and the functioning of people with severe mental disorders. And then now moving to the conclusion, I would like also to share with you some other scientific, let's say, papers that, according to me, are very important and give us the theoretical basis for being here today. This is a paper published some months ago in a very important journal for psychiatrists that is called Lancet Psychiatry, and this is a group of very important expert psychiatrists from different countries worldwide, from US to UK to Australia, and in which they state a very important thing, that sport represents a specific tool for recovery in people affected by severe mental disorders. And why they state this? Because sport can improve physical health and well-being, can increase social interaction and social skills, and can increase self-efficacy and self-esteem. And so I guess that these statements are very, very important, because really these highlight the need for a project like the one we are doing today, that is building a bridge between the world of psychiatry, let's say, of psychiatrists, of healthcare professionals, and the world of sport. You are today the sports world, I am today the world of psychiatry, and we are trying to collaborate to each other, and we hope that under the framework of the EASM project, this would be even if more possible. And this because also, for example, the European Psychiatric Association, which is another partner of our consortium in the EASM project, has also released this guidance paper a couple of years ago, stating the importance of physical activity for the treatment of people with severe mental disorders. in particular, the statement of these of the association, that again is an association of psychiatrists and of all the healthcare professionals working in the field of mental health, state that physical activity, as you can see here, can be used for mild moderate depression, can be used as an adjunctive treatment for people with schizophrenia spectrum disorder, and that in general should be improved and promoted for improving physical health in people with severe mental disorders, and that all people should be screened for physical activity habits in primary and secondary care. Again, this highlights the fact that we as mental health professionals are starting to think about sport and physical activity as an aspect really important to be fostered in the life of our patients. And another important association that is based on the collaboration of different academies in New Zealand state that the possible link for doing that requires three things: a cultural changes, and infrastructure changes, and also training program. And so I would say that with the EASMH project, we have this ambitious aim to fulfill these three aims because we are promoting a cultural changes. We hope to support change in infrastructure, and as today we have started with specific training. And as Valerio stated at the beginning of this session, the present project is based on the results of a previous project coordinated by ECOS called SPHERE, and the SPHERE project has released guidelines on how to promote sport-based intervention for people with severe mental disorders. These guidelines are available not only in Italian and not only in English, but also in other languages. And then I will provide you with the link where you can download the different version of these guidelines, because according to us, it is important that when you will think about the pilot action to be implemented in the next months, you will take it in your mind these SPHERE guidelines. And in particular, as Valerio already stated, within the EASMH project, we aim to build and to promote this training program in order to improve the kind of sport-based intervention that can be provided to people with severe mental disorders. And so this was my last questions, and I am happy to answer to any questions and to have a discussion with you if you have any other kind of also suggestion or everything you think.
Don't be shy, come on.
Thank you, Stefano.
Alejandro, don't be shy. Ask questions. Half in Spanish, half in Italian. Don't worry.
Allora, l'unica pregunta che verrebbe è se come dire, il beneficio, il vantaggio che può apportare, insomma, come può contribuire l'attività fisica a, diciamo, in questo sistema, se è una cosa, diciamo, comunque verificata, consolidata e utilizzata nel mondo, sta utilizzandosi da ora, da quanto tempo? Non so se capisci la domanda.
So I guess that, thank you, Alejandro. I guess that if I understood correctly, your question is that from how many years we have started to recognize sport as a relevant activity for patients with severe mental disorders? Is this the question? Da quanto tempo lo sport?
Yes, if is there scientific evidence about the benefits?
I would say that unfortunately it is just a quite recent issue, because as I have shown you from these documents from Scientific International Association, these are dated back almost 5 7 years ago. So it means that in the past, we didn't think about sport as a possible activity to be used for improve the life of our patients. Of course, I guess that it is really astonishing, this data, because really in the fact that sport activities are so have so many benefits for people with for people in general is a sort of self-evident concept, and so it is quite strange that just for psychiatric patients this concept has not been applied earlier. But I would add that probably it is not strange if we think that there is the problem of stigma and the problem that we think that patients for many years the most frequent idea was that patients with severe mental disorder should be just controlled in their symptoms, that the main objective to be fulfilled was just to reduce symptomatology and not to obtain the full recovery. But now we have had a complete shift toward the full recovery, and now we have started to be interested in this also dimension of improving quality of life, functioning, and all other things. And so for this reason, now we are also thinking about sport. So thank you, Alejandro.
Yes, thank you. Thank you.
Any other question, Retu, Alex, Serbu, Sami, Luis? Luis, are you trying to say something? Okay. If there are no questions, I would like to ask you a sort of general comment regarding the things that we have discussed today. Are these completely new concepts for you, or is something that you have already had the opportunity to think about in your life?
No, di difficoltà nei concetti, no, insomma è chiaro. L'unico come riflessione che mi viene da pensare sicuramente, e nel caso particolare quello che facciamo noi nell'attività sportiva, questa informazione mi fa riflettere tanto sul come farlo, sul cosa, diciamo, è sempre un'attività sportiva, fisica e ci penso sul come, perché sono tutte informazioni che mi vengono, che evidentemente sarebbero o potrebbero essere, me lo immagino, in un contesto diverso al quale svolgo allenamento tutti i giorni o attività fisica, solo questo come riflessione.
Mm-hmm. So thank you, Alejandro. And so Alejandro told us that the concept that we have discussed today are clear and are well received, but probably he is struggling now on how to apply, let's say, or how to behave in his ordinary practice in sport activities, taking into account all these concepts that I have tried to explain you today. And so I guess that the difficulties now is to combine these two dimensions. But I would like to add that in the next sessions, our aim, my aim, will be exactly to try to find an answer to this question, Alejandro. So we have developed all the toolkit, the educational material, having in mind this difficulty that you as sport coaches could have. Also because we know that people with severe mental disorder are not really the same of people without these mental disorders. And so in the next sessions, we will try to identify and the problems, the obstacles, but also to provide you some tips on how to implement these activities with people with this kind of disorders. And furthermore, I would like to say that the slide that I have used this afternoon, we will send it to you by email so that you can take another look on all these topics. And furthermore, as you have seen in the program, the next session will start with just a very brief recap of what we have discussed today. So please start thinking about who will do it for the next time. It will be one person or two questions. It is a very, I would say, a little task, because of course we will not have the time to go in detail to all the aspects that we have covered this afternoon, but just a global overview, just for being sure that something has been kept in our mind and that we can move on different topic. And we do like that in all the sessions that we have, in order to have a sort of refresh of all the topics before moving on. And so other questions? Alejandro, stop questions.
No, basta, ho finite. So I stop the next week.
Retu, Alex, any other questions? No. Okay, so I ask also Stefano, I don't know if I forget to say something. Would you like to add something about from a logistic point of view?
No, just that you send all these slides to everyone so you can read them again, and then let's meet the next week.
Yes, okay, so next time is on Monday.
And also regarding there will be more interactive parts in the next lessons, or there will be role playing, so please try to be more interactive, and so Gaia won't be so tired at the end of the lessons if you all will interact and ask questions.
No, thank you, Stefano. And in particular, I would say that for the next sessions, interaction is, of course, highly welcome, because we will have also some role play sessions, and so we will need to interact each other in order to make it useful for all of us. And please, really don't be shy, because it is true that we are recording, but it is also true that this is a sort of pilot event, even if for us as trainers. So please, again, don't be shy, and every kind of feedback is welcome. I guess that in the following days, probably you will receive also some very brief questions for providing us a comments about what to implement, what to change, how to do better in some part of the course, and so don't be shy neither for this activity. And then I am very happy to have had the opportunity to meet all of you this afternoon, even if at a distance with Zoom. But I guess that it has been a successful session, and I really hope to have been able to communicate with you all the complex topics that we put in this presentation. And if you like, please write also to me an email, and I will be happy to reply to you as well, to provide any other kind of feedback. And also in the next sessions, please ask if you need any kind of help. Okay.
Okay.
Okay. So now I will going to stop the recording.